Welcome to The Explainer. Today, we're taking a pretty fascinating journey straight into the electrical mechanics of the human heart. Now, have you ever wondered what happens when the very system designed to keep us alive suddenly just goes rogue? When it pushes our heartbeat to these dangerous, chaotic speeds? Well, today, we are decoding the heart's electrical storms. Specifically, we're looking at a group of conditions known as tachyarrhythmias. We'll be relying on insights from the definitive text, Cardiac Surgery, to really understand not just why these storms happen, but exactly how modern medicine maps and pacifies them.
Okay, let's dive right into this. Here is our roadmap for today. 1. The runaway heart. 2. Wolff-Parkinson-White syndrome. 3. Atrial fibrillation and flutter. 4. The Maze procedure. 5. Ventricular tachycardias. And 6. Modern rhythmic rescues.
So starting off with Section 1, the runaway heart, focusing on abnormal tachycardia. To really grasp what happens when the heart's built-in pacemaker goes into overdrive, we first need to define the actual problem. You see, abnormal tachycardia isn't just a fast heart rate. I mean, if you're running a marathon, a heart rate of 160 beats per minute, that's completely appropriate. But abnormal tachycardia is a rapid heartbeat that is entirely out of proportion to the metabolic demands on your circulation. Imagine you're just sitting on your couch, completely at rest, but your heart is sprinting like you're being chased by a bear. It's this pathological overdrive that seriously compromises the heart's ability to efficiently pump blood. And the craziest part? It's driven purely by electrical rebellion.
And, this is not a new mystery. Way back over a century ago in 1909, Sir Thomas Lewis highlighted the urgent need to understand these exact conditions through a controlled study of inducing tachycardia. For decades, these electrical storms literally baffled physicians. It actually wasn't until the advent of programmed electrical stimulation and advanced cardiac electrophysiology in the late 20th century that doctors could finally start mapping these pathways. Modern electrophysiology has literally become the ultimate internal detective work.
Moving on to Section 2, Wolff-Parkinson-White or WPW syndrome, which is essentially an anatomical short circuit.
Take a look at the visual contrast here. In a normal heart, the electrical signal travels from the top chambers to the bottom chambers through one single designated pathway. But check out the other side. In WPW, there's this rogue extra connection. It's an atrioventricular bypass tract, which is often called a tent bundle. And this bundle creates a really dangerous secondary loop, essentially allowing the electrical current to just completely bypass the heart's natural traffic control system.
So you might be wondering, how do doctors actually spot this hidden pathway? Well, they look for the smoking gun on an ECG. Because that rogue cant bundle allows the signal to reach the lower chambers early, it creates some very specific squiggles on the monitor. The classic hallmarks are a shortened PR interval, a broad QRS complex, and the famous delta wave. It kind of looks like a little slurred-up stroke right before the main spike. When doctors see these signs, it confirms early, unauthorized ventricular activation. To put it simply, think of the heart's normal AV node as a vital toll booth. Its job is to briefly delay the electrical impulse, which ensures the top chambers actually finish squeezing blood into the bottom chambers before those bottom chambers fire. But the Kent bundle? It's basically an open highway with zero speed limit. It completely bypasses that safe delay, causing dangerous pre-excitation. And when this fast pathway connects back with a normal pathway, it can create this continuous revolving door of electricity. It's a reciprocating tachycardia that sends the heart rate absolutely skyrocketing.
All right, Section 3, atrial fibrillation and atrial flutter.
Leaving the rogue highways of WPW, we enter a much more chaotic, disorganized world. In atrial fibrillation, or AFib, the upper chambers of the heart essentially stop beating effectively. Instead, they just quiver because they're being bombarded by hundreds of disorganized electrical impulses. But this disease isn't static. It evolves over time. Clinically, it's broken down into 3 main stages. First up is paroxysmal AF, which is intermittent and stops on its own within 7 days. But if the chaos continues past a week and requires medical intervention, it progresses to persistent AF. Finally, if the heart remains in this chaotic state continuously for over 12 months, it gets classified as long-standing persistent AF. Seeing this progression really highlights why early intervention is just so critical.
And this brings us to the first line of defense, the chemical rescue. When a patient is stuck in AFib, doctors often turn to very specific classes of antiarrhythmic drugs to try and cardiovert the heart, snapping it back to a normal rhythm. Class IA and IC agents work by slowing down the electrical depolarization. Think of it as essentially putting the brakes on those fast currents. Meanwhile, Class 3 drugs like amiodarone actually prolong the heart's action potential, increasing the time it takes for the heart cells to reset.
It is a highly complex pharmacological balancing act, all aimed at getting the electrical grid back in line.
Which leads us to Section 4, the maze procedure, or what we can think of as surgical rewiring.
So what happens when medications fail? Well, the surgeon steps in as a master electrician rewiring a house. Here in the Cox Maze 3 procedure, you can see they make a highly precise, carefully planned series of incisions, literal cuts, across both the left and right atria. The entire goal here is to stop the electricity from spinning in those chaotic, re-entrant circles.
Now, why make these cuts? It all comes down to how heart tissue heals. The cuts create scar tissue, and electricity simply cannot travel through a scar. By doing this, the surgeon is creating literal electrical blind alleys. They are building walls that interrupt those chaotic spinning circuits, while simultaneously forcing the heart's natural electrical impulse to travel down one single specified, controlled route straight from the natural pacemaker to the AV node. It's honestly a stunning architectural fix to a deeply complex electrical problem.
Moving down into the heart, Section 5, ventricular tachycardias. These are the lethal lower chambers.
I really want you to absorb this number for a second. 60%. That is the in-hospital mortality rate for patients who develop sustained ventricular tachycardias late in their recovery from a myocardial infarction or a heart attack. When the thick, muscular lower pumping chambers of the heart fibrillate or beat too fast, blood just stops flowing to the brain and the body entirely. It is a massive, immediate, life-threatening emergency.
Unlike WPPW, which you're born with, these lethal lower chamber arrhythmias are very often rooted in acquired ischemic heart disease. When someone suffers a heart attack, part of the heart muscle dies and turns into scar tissue. Now that scar tissue is electrically dead, but the healthy tissue right around it is still alive. This creates the perfect anatomical racetrack. Electrical impulses get stuck, circulating endlessly around the border of that scar, creating a macro reentry circuit that drives the heart into a deadly, uncoordinated spasm.
Finally, Section 6, modern rhythmic rescues, the technological fixes.
I want you to compare that grim 60% mortality stat we saw just a minute ago with this number, 98%. That is the astonishing success rate of implantable cardioverter defibrillators, or ICDs, in terminating ventricular fibrillation. These are tiny, hyper-sophisticated computers implanted just under the collarbone with wires running directly into the heart. They sit there monitoring every single heartbeat, 24/7. And if they sense a lethal rhythm, they can immediately deliver a life-saving shock or rapid pacing to reset the heart in a matter of seconds.
So knowing exactly who needs this incredible technology is crucial. As detailed in the ACC/AHA guidelines, the Class 1 indications, meaning there's universal medical agreement that these are necessary, are incredibly strict. They include survivors of sudden cardiac arrest and patients whose left ventricular ejection fraction drops below 35% following a heart attack. It's also mandated for patients with severe non-ischemic cardiomyopathy or those with unexplained fainting who have these deadly rhythms triggered during clinical testing. It's a very objective, data-driven approach to essentially placing an emergency room permanently inside the patient's chest.
Which leaves us with this final thought. We have gone from the early 1900s, where these rapid heartbeats were a complete and total mystery, to an era where we can surgically rewire the heart and implant automated defibrillators. As catheter ablations become even less invasive, and as ICDs become continually smarter through artificial intelligence, how will future technology continue to map, master, and pacify the human heart's incredibly delicate electrical grid? It's an absolutely thrilling frontier in medicine. Thank you so much for joining me on this explainer, and keep questioning the incredible mechanics keeping you alive every single day.